So let's start this symposium. Unfortunately, the previous meetings were a bit late and there are still many people busy with lunch, but thank you for coming. And we'll try to put together, as you can see from the prominent names of speakers and panelists, a quite nice sessions, practical on how to use lithotripsy, but also dealing with the new data that have recently been presented. And in fact, I've been asked to speak about two recent presentations at TCT that may have caught your attention. And I have to first acknowledge that, of course, this is a sponsored meeting. Well, first of all, coronary calcification, around 20-25% of all the lesions we treat are a problem. And these are data that you have seen many times, showing that no matter which type of MACE you consider, death, cardiac death, MI, thrombosis, target lesion revascularization, early or late with first or second generation drug-eluting stents, but calcified lesions do worse than non-calcified lesions. For this reason, we have algorithms that should try to improve our result. Our PCI result in calcified lesions are not as good as in non-calcified lesions. As we said, we want to select those lesions in which you don't have sufficient expansion. And I think the best data so far are these data coming from both intravascular ultrasound imaging and optical coherence tomography, both from the group of St. Francis, Columbia, and they indicate that the presence of an arc of calcium complete or greater than 270 degrees, longer than 5 millimeters, for IVUS in larger vessels or presence of calcified nodules are all bad omens that indicate worse outcome. Recently, these two criteria that has been endorsed, as you can see, by the European interventional associations, has been slightly modified by Dr. Mahara. She has simplified the score that you achieve with OCT, and now you have 3 quadrants, so the rule of 3 instead of the rule of 5, 270-degree arc of calcium, or presence of a 360-degree complete Napkin's ring of calcium, or of a thickness of calcium of more than 0.3 millimeter. These 3 criteria alone predict better than the previous algorithm incomplete expansion to less than 70%. If you look at the derivation and validation cohort of this study, you can still appreciate that sometimes you may have some lesion that, despite having a high calcium score of 2 or 3, expand reasonably well, but you are able, with this number, to catch most of the lesions that do not expand. And that's, I believe, the main reason why we like to use this criteria, to know when you have very high likelihood not to expand properly and you need, therefore, dedicated devices. Which dedicated devices? These, I believe, are a true active energy delivered at the site where the calcium is, to modify it physically, either with ablation, rotational atherectomy, or orbital atherectomy. Laser is a bit more questionable how much it does on calcium, but still has to be considered in this group. Probably lithotripsy is the one that has more potential to act, including deep calcium. I think it's logical to compare them with devices that may be applicable to calcified lesion, focusing the energy of the balloon dilatation to a specific point and cutting through calcium, or using extremely high pressure, 35, 40 atmospheres like the OPM balloon, to expand calcified lesions. And what the trials I'm going to present in a second have addressed are, I believe, very important questions. Are these devices interchangeable? Can we use the simpler device, less expensive device, in place of the more complex and costly devices I've shown in my previous slides, are maybe applicable in some specific lesion. Are they safe? Well, the two trials that I'm going to present, Shortcut and Victory, both just presented a few weeks ago in San Francisco at TCT, are true randomized trials, also in small number of patients. So the endpoint is not a clinical endpoint, it's a mechanistic endpoint of stent area or final stent expansion, both assessed with intravascular ultrasound or optical coherence tomography. You have the impression that these are imaging-based studies. In reality, as you will see, the criteria were mainly angiographic criteria of inclusion. And in my view, this has been the main problem why both of them came up non-significant in favor of lithotripsy, with the possibility then to show with non-inferiority these simpler devices, cutting balloon or high-pressure OPM balloon. To try to explain why I believe this is the case, let me go back one step to a trial that we are all aware of, presented in fact a couple of years ago, but recently published, the ECLIPSE trial, a very large trial of more than 2,000 patients of orbital atherectomy versus high-pressure balloon dilatation. Scoring or cutting balloon were used in a minority of patients. Very recently, we had a report that gave us in detail the results of the 44% of cases where OCT was done. First of all, let me remind you the inclusion criteria. In theory, they were complex severe lesions, 70–100%, or if they were between 50 and 70 with evidence of ischemia, but this can be just a treadmill test. In reality, you see the mean diameter stenosis of 67%, especially in a large vessel. You are all aware that a device like rotational or orbital atherectomy may even not touch the wall in these conditions. The other issue with the OCT, the maximum arc of calcium in this lesion, also all of them as angiographically severe calcium, was only 204. So below, on average, what is considered the indication with the trial I've just shown before for the use of dedicated device. Thickness was all right, 0.85, length was all right, 22, so we don't know whether, again, how much the arc was. The result showed that with orbital atherectomy, you truly modify the plaque, you increase the number, length, and depth of calcium fracture compared with balloon angioplasty, you achieve a somewhat larger area, 7.44 versus 705 millimeters square in this OCT sub-study. However, this is not sufficient to modify your final clinical endpoint. And we all know that the larger the vessel, the larger the lumen you achieve, the greater the possibility somehow to reach those absolute criteria of area, 5.5 millimeters square, that predict anyway a good outcome. So this was, in theory, what was the base for the sample size, so 4.5 millimeters square of area in the control arm. You have seen that numbers were very different. And I think this justifies the negative outcome of the trial. Not completely negative. There is a difference in stent area at the maximum calcium site, 744, 705 in the full population, but not sufficient to modify the clinical outcome in these patients. And I think was a necessary premise to understand better the result of the other two trials I will discuss, starting with Shortcut. In my view, besides selection of patients, the other mistakes in this trial is that Americans love their rotational atherectomy, and they accepted that the investigators could decide, based on the complexity of the lesion, to say that's a case where I want to do my rotational atherectomy first. And in fact, this happened in half of the cases. Of course, this may modify the response to cutting balloon or intravascular lithotripsy. The endpoint, again, was mechanistically the maximal area at the site of the calcium. And as you can see, the inclusion criteria was mainly angiographic. Also, it was considered the possibility of using the classical intravascular ultrasound criteria, but they were not truly the same as in the slide I've shown before. For instance, the diameter is not considered, and the vast majority of the cases were angiographically driven in terms of inclusion. Again, mandatory IVUS just after randomization for the assessment of the final area and not for selection of patients. Reference vessels, they were large vessels, and again, in terms of clinical outcome, you know that you may achieve in this vessel, even in presence of severe calcium, sufficient absolute lumen area to limit the number of events. Arc of calcium, well, quite large, as you can see. However, around 26% had less than 270 degrees in both groups, and I'm not sure the nodular calcium, that we still don't know 100% how to treat, was a good idea to be included in this trial. The way lithotripsy was done is not the way we do. Of course, we have an expensive device. We use all the energy, 120 erogations and 120 pulses in all cases, while here the average was 90 and some were as few as 60. This was the result, showing that with lithotripsy you achieve a larger lumen. In fact, not a minimal difference. It's 0.6 millimeter in terms of minimum stent area at the site of the maximum calcium. A difference that, however, did not meet the non-inferiority criteria. Why? I think that was the main reason, because half of them had the randomization and the use of the two different devices done after rotational atherectomy. And after rotational atherectomy, the two groups had a superimposed area. There is a very recent trial just presented, the ROTA-CAT, published in Eurointervention a few months ago, again, small mechanistic, 60 patients from Mount Sinai, and they did cutting balloon or non-compliant balloon after rotational atherectomy, no difference in the area achieved. I mean, you understand why. If you look at the maximal pressure in the group with non-compliant balloon, is 16 atmospheres. Is it what you use in severely calcified lesions? Of course, they can do, because they were all pre-treated with rotational atherectomy, that somehow minimizes the difference between the two devices. If you consider the group not treated before with rotational atherectomy, the difference is larger, almost 1 millimeter, and the value for non-inferiority is not achieved. So intravascular lithotripsy is better than the use of cutting balloon for calcified lesion. Victory used the OPN balloon, again, mainly angiographic criteria. There was also the possibility to use OCT, but just the arc of calcium greater than 270 degrees, and again, majority of cases were just based on angiography or inability of a first balloon to dilate. As you can see, moderate angiographic calcium was present in around 1/3 of cases, large vessels, non-inferior, similar to what has been shown in the overall population of the shortcut trial. Also in terms of safety, again, limited number of patients. There were no difference in flow limiting dissection and in coronary perforation or no reflow. Maybe not something we are used to see in our normal practice. Same for the shortcut trial. In terms of adverse events, they were extremely low in both groups. I mean, we are all aware of how well documented is the extreme safety of intravascular lithotripsy in truly complex lesions like the one that has been enrolled in the DISRUPT trial and this large meta-analysis presented by Dean Kyriakis a few years ago with 0 perforation induced by the lithotripsy balloon, very few overall, and very low numbers of angiographic complications or flow limiting dissections. I think it has been these are in fact the American interventionalists who understood that and made the difference. After the approval of lithotripsy, the number of dedicated devices for treatment of calcified lesion increased, with lithotripsy somehow eating the space of rotational atherectomy with very limited penetration of orbital atherectomy and with a relatively low percentage of cutting balloon angioplasty. This is the Italian series in the GISE registry of 2 years ago, and again increase of number of dedicated devices, with Shockwave being the one used most frequently. My conclusion is that I will not change my algorithm of treating calcified lesion based on these 2 trials. I believe that, of course, if you apply lithotripsy in non-calcified lesion or in non-sufficiently calcified lesion to make a difference, that's not a good idea. Selection is key. The inclusion in randomized trials, in general, irrespective of these 2 trials, tend to skew patients and lesions towards cases with low complexity, and this makes it unlikely to demonstrate the benefit of any new tool. And we have to acknowledge that and understand that, of course, these investigators did their best, and the negative result can be, however, explained by this selection bias. Shortcut, the largest of these 2 trials, anyway, showed that IVL obtains a numerically greater lumen area that was, in fact, significant if you eliminate the confounding effect of rotational atherectomy before cutting balloon or lithotripsy applied in half of these lesions. And I think that I will maintain my high use of intravascular lithotripsy like most of our American and European colleagues, based on safety, efficacy in routine clinical practice. Thank you. I think it's probably better, if you don't mind, to give the 3 presentations together and then discuss everything at the end. So I'm very pleased to call the second speaker, Dr. Ahmed Al-Sherri from Saudi Arabia, to present also 3 new trials in the field.
So from trials to practice, the latest Shockwave IVL data transforming a PCI with a unique mechanism of action. I organize it in a way that we'll start, this is a sponsor session. So we'll start with this first trial. It's the Cadaveric trial. So remember it as a Cadaveric, impact of the Shockwave IVL, Wolverine, and OPN in severely calcified coronary lesion. This is a very, very interesting trial. So let's go with this. So the evidence comparing the mechanism of action of lesion preparation, the strategy needed to help informing ideal treatment prior to definitive therapy. So you see in the OCT here, there's a calcification, there's deep calcification on this side, and there's a calcified nodule on the other side. And the fluoro and an NGO, you can see the instant, the under expansion secondary to calcification. So preparation of the lesion is the key on this kind of cases. So let's see what they have done. So the cadaveric specimen used to compare strategy. They got 6 hearts, and in that 6 hearts there's 17 lesion, and the characteristic of the lesion, more than 50% stenosis on angio and OCT, more than 50 millimeter lesion in length, and calcified plaque on angiogram and OCT. So they categorize them to 5 patients that go to the Shockwave with the C2, and they use 120 pulse, so full-blown management. The 5 lesions, and with the Wolverine, the cutting balloon, 6 lesions, and in the OPN high pressure balloons on 6 lesions too. And just to look at the characteristic of using in the Wolverine and also in the high pressure balloon. So this is a full therapy that was given for the Shockwave. This is an inflation pressure to 18 atmosphere, balloon size according to the images and the fluoro and the OCT images. And in the OPN, the inflation pressure at 34, balloon downsized to 0.5 millimeter to the vessel size. So they were being conservative in using the OPN if you wanted to read it this way. And then you can see the assessment was done utilizing the advanced imaging techniques possible with the cadaveric specimen with the micro CT and the histology. And we want to go through this very cool images. So you can appreciate that the calcium fractures, you can appreciate it in the histology and from the intima to the media. And also in the histology with the medial injury. So the calcium fracture, one finding. Second is the medial injury or disruption. So the medial injury can potentially affect long-term clinical outcome due to the increased neointimal thickness, higher inflammatory cell count, and instant restenosis as compared to lesion without medial injury. That does make sense. The atheroma and the atherosclerosis happens because of the inflammation to start with, and the calcification is as healing process. So, and the calcium fracture was mostly frequently observed with the Shockwave IVL. The medial injury was significantly less frequently to the IVL compared to the cutting balloon and the OPN. And you can appreciate that the fracture is the maximum in the IVL group, and the medial injury is the minimal in this. And you can appreciate that the OPN, for example, it carries the highest medial disruption. So medial injury occurs 100% of the lesion treated with high pressure balloon, even that they were conservative with the balloon sizing, and or even with the pressure. If you look carefully here, I want you to see how the fracture in the IVL and the histology. You can, if you see that this is the vessel size, and that is the deep to the tissue, and you can see that there is a wide fracture and with no disruption of the media. But look at this. So this cut is from here. So the pink toward the vessel, and the black is the outer layer or the media, the external lamina. And you can appreciate that the intima, there is a fractures. You can see in the cutting balloon there are some fractures, but the media, and there is a disruption of the media itself. And if you look at the one with the OPN, you see that the things are seriously disrupted. Again, the calcium fracture and this is the same finding. The cutting balloon produces a fracture less than 50% of the histology section, and no calcium fracture identified with the micro CT and the histology in the OPN. So it's all medial injury. So that tells you that if you wanted to fracture the calcium with lowest medial injury, this is the best technology that is available for this particular sake. Let's go to the second trial. So randomized BALI data enlightened in PCR late breakers at the benefit of routine use of IVL strategy. and to compare to the is it superior or inferior than the conventional strategies. So is it the first thing that you draw from your shelf as the IVL for a calcified lesion or not? Then that is the answer. So it is obvious why we want to do this. We wanted to shorten the procedure and also enrich the data and the literature, and because of a limited randomized evidence exists comparing the calcium modification techniques. And the way that we do, they have done that is the IVL is versus conventional balloon-based strategy, including cutting, scoring, or OBN or ultra high pressure balloon. Rotational atherectomy permitted to facilitate crossing. And you can, this is something that you will see in every study that goes to our trial, that it's studies the calcium modification. So how it's a randomized, this is the BALI trial. It's a randomized imaging-based study with a novel superiority endpoint that analyzed a procedure and long-term outcome. So it's 1-to-1 randomization, 200 patients, multicentric, and follow-up of 1 year. The primary superiority endpoint, procedural failure, composite of procedural failure, no or failed stent delivery, and OCT assessment residual area stenosis of 20% and above. So target vessel failure at 12 months follow-up, the MI, the clinical driven revascularization, and cardiac death. So let's go through this in carefully, because this is a very interesting trial. BALI is the first coronary randomized shockwave funded study IVL versus conventional balloon-based strategy. The inclusion criteria of this patient group: a severe angiographic calcification, chronic or acute coronary syndrome, evidence of ischemia. The exclusion are STEMI, CTO, low ejection fraction less than 35%, and poor kidney function less than 30 of a GFR. The randomization, the angiographic, the randomization, you can appreciate that the same number on both arms, Shockwave arm, they used to facilitate with the rotablation if criteria met, lesion preparation with the Shockwave, pre-stent OCT, stent implantation, post-DEL, post-stent OCT, and then 12 months follow-up of the angiogram plus OCT. The other side is the conventional that we do using the cutting or the OPN or scoring balloon. Balanced characteristic between the two arms. Vessel, you can appreciate that even the left main and the Shockwave arm, they've been tried. The left circumflex is the lowest vessel, or the less frequent vessel to be treated with in this trial. But the LAD and the RCA are the one to go. You can appreciate that the tortuosity on the tortuosity on the IVL arm is higher, and the diffuse disease is also higher in the IVL arm. It's very important to notice this. The procedural characteristic, you can appreciate here that the rotational atherectomy facilitation was done in 30% of the cases of the IVL arm, and it's in 40% on the conventional arm. And the stent implantation, we'll go to the data here. The IVL demonstrate superiority outcome at 1 year follow-up. I want you to see the endpoints in this. So the endpoint is failure or a residual. So it is a negative endpoint. So if you have a less number, it's good. So the primary endpoints is 35% in the IVL group, and it is 50%, half of the cases. They have a positive primary endpoint. If you noticed, it's mainly, it's not the failure of the stent delivery. It is the residual area stenosis, more than 20% by OCT. It is significantly higher in the conventional group. The target vessel failure is lower in the IVL group, as well as all the other numbers that is of the targeted vessel failure. So If we to sum up this information and finding, over two-thirds of patients with the routine IVL were free of primary endpoints, compared with approximately half of the patient with a conventional treated arm, leading to BALI investigator to determine that at 1 year, a routine use of IVL was superior in lesion preparation strategy than conventional. The safety, the safety of the device-related complication is low, with only one perforation occurs in each group. That is giving the fact that this is a calcified lesion and things can happen. Occurring to each group inside the stent segment, each occurring during stent implantation. So it is not the modality itself, it's what is after that. So no perforation within the IVL arm were directly related to the IVL usage. One in-stent perforation during the stent implantation, one perforation proximal to the stent segment, and two distal wire perforations. Look at this one. So the outcome of the instant MLA and the residual area stenosis numerically favored IVL. So an IVL, the MLA instant MLA, it's higher in the IVL group. The residual area of stenosis is lower in the IVL group, and the late lumen loss, it's the same in both arms. So in conclusion, by this trial, we can declare that, or give a finding that positively finding that the complex patient population with the severe calcified coronary lesion was shown to be superior when you use the IVL compared to the conventional balloon-based strategy. IVL continued to be safe, and in the Shockwave confirmed to be effective. So it is superior, safe, and effective. In patients who undergoes PCI with severe calcified coronary lesion, the usage of IVL before stent implantation reduced the incidence of procedural failure or target vessel failure at 1 year without an increased risk of adverse event. And this is a very cool study to notice and to refer to, which is BALI trial. Last but not least, talking about the they checked on the benefit of the IVL as a first strategy confirmed in females. It's a bit interesting to segregate it this way, but however, look at this. A woman, coronary calcification and PCI risk. They are underrepresented in the PCI trials, the woman, diagnosed in the coronary artery disease at older age with more comorbidities, subject to high risk of complication when calcified lesion are treated. You can appreciate that in the curve here, the time to death and also the coronary artery detection, the woman is higher than the men into that part. So let's go to the Empower Coronary Artery Disease trial. The objectives is female only. All comers study to generate real-world clinical evidence associated with IVL first strategy in patient population with calcified coronary artery disease. The design is a prospective multicentric single-arm female only, all comers, and the follow-up is for 3 years. And the inclusion is the female that are non-pregnant more than 18 of age, meet indication of percutaneous PCI, scheduled for undergoes PCI with a coronary IVL and stenting per standard of care for non-stented lesions. End points, the primary safety endpoint, target lesion failure defined as a composite death, myocardial infarction, attributable to target vessel myocardial infarction, and ischemia-driven target lesion revascularization. It is at at 30 days, and the primary effectiveness endpoint, procedural success defined as stent delivery with a residual instant stenosis less than 30% in all target lesions. and without in-hospital failure. So look at the risk. I mean the demographic of the group that are being studied in the female cohort. So all kind of BCI indication less into the STEMI group. 50% or half of them is diabetic, most of them is hypertensive, most of them is dyslipidemic. 1/3 of them they have prior MI. 40%, almost 40%, they have prior PCI, and chronic kidney disease of at least almost 1/3 of the patients. So this kind of patient is a high risk to start with, and they're females too. The way that this has been designed, the Empower Coronary Artery Disease study, over 90% of lesions were treated with Shockwave IVL first treatment strategy. So the planned PCI with IVL and eligibility criteria met. Then enrollment comes here. So IVL pass the lesion. If yes, IVL treatment and post-IVL imaging, and then stenting. And if no, adjunctive therapy or modality, optimal result. If not, IVL. And if yes, we can go to stent. So IVL can be was used as a bailout to the adjunctive therapy when the IVL is not passed. So again, the facilitation of atherectomy was in 7% of the cases. So the actual what happened is that 399 patients were enrolled, and mostly the pre-IVL dilatation was applied. Less than 10% of the atherectomy was used, and then IVL first IVL approach in 90% of the cases, 407 out of 449, and stent implanted successfully in 98% of the cases, and dilatation in 92% of the cases. Again, the target lesion characteristics as you can appreciate from looking at the core lab data that this is the kind of cases that it is difficult to be treated. So 1/3 of them is bifurcational, severe calcification, of course, into most of the cases. And you can appreciate that good coverage of all kind of vessels, circumflex, LAD, and RCA, as well as the left main in 7% of the cases. So IVL demonstrated favorably safety outcome in hospital at 30 days and at 30 days follow-up. So the target lesion failure within 30 days is 12%. The cardiac death is less than 2%, is 1.3%. And spontaneous MI more than 48 hours happens that more than 48 hours from the index procedure is 1.5% only. So the protocol requires systemic biomarker collection in all patients. MI rate reflected the complex patient population, and majority of the MI were biomarkers elevation alone without clinical outcome. 1 minute?
You're a bit...
1 minute?
Press by
Okay.
time, sorry.
It's okay. So 1 minute. So IVL proven to be effective in calcium modification strategy of all comers females population. You can see that successful procedural successful. The procedure was successful in 87% of the cases. And the quality, and by survey, the quality of life at 30 days is favoring the IVL first strategy. And the complication is somehow the same from in both sides. However, it's favorable to the IVL first. So in conclusion of the Empower trial, Shockwave IVL is the frontline calcium modification strategy is safe and effective in female patients with a calcified coronary artery disease. Real-world female patient population more complex than disrupted coronary artery cohort. Shockwave IVL maintained to be strong safety option. IVL low angiographic complication confirmed across both male and female patients. So by this, I can assure by the 3 trials that it is effective, the IVL is effective, safe, and also that it has the best calcium modification without medial disruption. And thank you very much.
Thank you, Dr. Alcherri. Let's move to our last speaker before starting the discussion, and Dr. Chandra Praveen from India.
Yeah,
Please.
Thank you.
Chandra.
So I think we are already quite late in this session, and I'll try to go a little faster now because of the time constraint. So what I'm going to share with you now is that after you heard the data presentations from so many trials and registries, we have to now go and discuss what is happening on a day-to-day basis. So that's what I'm going to discuss, and this will be part of my presentation. And as you can see here, this is the data which we have done up till now. We did a very big registry in India, which is known as Shock India Registry, which was 1,000 patients. And from our center, in fact, 20% of our patients were from my center. And this is up till now, 18,000 patients have been treated in India since January 2020. And now I'm today going to also share with you my own personal experience of more than 700 cases of IVL done in the last 5 years. So that is going to be, and this is the quickly run through of the Shock India Registry, which was presented many times in various other meetings. It was a study with the OCT sub-study of 100 patients. And here you can see that the results were quite spectacular, that the MACE at 1 year was only 2% and cardiac death was only 1%. So it was quite effective, and the incidence of complications like stent thrombosis was also quite minimal. And as you can see, the procedural success was also above 99%. So that is something which was very important. Then the question comes when we treat calcified lesions is, what are the complications which happen when we treat calcified lesions? One of the common complications is severe dissection. It was hardly seen. Perforation. When we do various kind of atherectomy devices, including cutting balloon or rotablation, we see perforation. Here the perforation rate was also very low in this Shock India Registry. Abrupt closure was also not seen, and slow flow, which is again a complication when we treat calcified lesions, was also very minimal. So what we are avoiding is the complications which happen when we treat heavily calcified lesions with atherectomy device. So what we are saying is that devices did exist, but they came with some complications. Here in this registry, we saw that the complication rates were minimal. The second is, what kind of calcium can we treat? So as you can see here, half of our patients were concentric calcification and half was eccentric calcification. So all kind of calcification. And then some discussion about the nodular protrusions. Nodular protrusions, we initially thought that probably Shockwave may not be effective, but we saw in the study that it was effective in this subset of patients also. And also if you see the OCT subset, we did calculate the maximum calcium angle, and of course the maximum continuous calcium angle. Everything was calculated, and we saw that in most of the instances it was reasonably effective when we saw the calcium fracture. And as you can see here, this was in the range of about 85%, which is quite effective. And this is just on simple routine as OCT. I'm not talking of micro CT here. So the fracture depth was also good, and the fracture width was also found to be quite amazing and quite nice. And as you can see here, the fracture width was both for nodular and non-nodular calcium was above 0.64 and 0.72, primarily because it was actually the effect of this therapy that it leads to cracks which go in various directions. It is not only perpendicular or horizontal, okay, which happens with cutting balloon or rotablation sometimes. So that is probably the benefit which we started getting with this device. And then of course it was studied, as was shown also in a Cadaveric example, that when you do a micro CT, you see that much more calcium disruption happens, much more calcium fracture is seen, as we cannot see everything on OCT or routine angiographic evaluation. So Quickly now moving to our own registry, which is about 700 patients now. And here you can see that we did imaging for everyone. So that is our way to do it. So now I'm going more towards how do we do it. So imaging is almost always 100%. But let me tell you one thing, it may not happen every time because many times you are not able to even cross the device. So many times we do either a rota or a balloon dilatation, and then we try to put a IVUS or OCT, still it doesn't cross. Then we do a shockwave, and then we do the imaging again. So imaging is done at various points in time, but at least definitely at some point in middle or before and then after. So to know what is the stent expansion. These are the steps to follow. So lesion identification, of course, by angiographic and OCT and IVUS. Then assessing the size of the vessel. Then IVL delivery. We emit all the pulses at the deepest calcification. And also, if there is a long disease, we go step by step, 2 millimeter steps, and then we do the whole fracture. And also wait for the balloon to expand. Then, once the fracture confirmation is done by either angiographic or balloon expansion or by IVUS and OCT, then we go for stent deployment. And then, of course, we again do a post-dilatation, and post-IVUS optimization is done for almost every case if required. So this is the quick run through of what we did. And here you can see that in our patients, diabetes is very rampant. 63%, and about 40% of our patients are acute coronary syndrome also. So it has a combination of thrombus also in about 25% of cases. So thrombus was existing, which was not an issue because especially in view of rotablation, if you start doing that with rotablation. So this is the the calcium thickness and the calcium arc, which was quite significantly there. Concentric was again 50%, and then followed by eccentric and nodular calcium. Bifurcation lesions, osteal lesions, underexpanded stents, and calcium score more than 400. So all this was our, the work which we did. And this is, of course, the maximum number of cases were done on the LAD, followed by RC, LCX, and left main also. So many times people say that if you do left main, what will happen to hemodynamics? So generally we do bursts of 5 each. So we do a burst of 5, wait, deflate, and then again do a burst of 5. So rather than going for the 10, you can do a 5 at one time. So that is the trick. And then, of course, these are the, the procedural other details of using other, adjunctive technology. So non-compliant balloon is almost always there. We use that. And then, of course, cutting a scoring balloon was additionally used in some patients. And atherectomy like rotablation or orbital was also done to cross the lesion in some patients. So these are the IVUS outcomes. I will quickly run through that. And this is the safety outcomes. Perforation was only in 5 patients out of 700. And that too happened in those patients where we did additional devices, like a cutting balloon before or after, or doing a rotablation also, and then we do this. So sometimes we saw that covered stents were put in 3 patients, pericardiocentesis only in 1. And no reflow was again very, very significant. No, very, very rare. We don't almost see that. And in hospital mortality was also very low, that too in a cardiogenic shock patient. So with this, this is the way we do long lesions, because typically in India we see a lot of long lesions where we have to use the same balloon or maybe sometimes 2 balloons to take care of that. For bifurcation in osteal lesions, as you can see here, in non-dilatable stents, we do the placement of this balloon where you can see that you have to place the emitters at the maximum site. So which may not be sometimes middle. It could be proximal or distal. So you can plan accordingly based on that. And then the other important thing, because perforation, the balloon ruptures happen quite frequently. So to prevent that, the only best way is to do is remove the air after 2 or 3 dilatations. As soon as you see the air stop, remove it. Just takes maybe 10 seconds, and then you can again start doing it. Because the balloon rupture, the second is effectivity of this dilatation may not be adequate. So that is how we are doing it. And of course, I told you about the the pressure, giving the pressure at the right site to get the best outcomes in these patients. So quickly, for multi-vessel disease, again, this is our good choice. Because in these patients, we do not want to do so many steps at the time, because one wire does it all. And one balloon sometimes does it all, because now with the multiple shots. So here you can see that there's it's a triple vessel disease, and here we are doing, first we did the RCA because that was the tightest, and here you can see that we did the dilatation, and then a Shockwave because IVUS is not crossing after dilatation. Do a Shockwave, do an IVUS after that, and then do a stent implantation with good results. And you can see how nicely the stent has expanded here. And then going to the the left side, sorry. So we move to the second case. Here you can see that we are doing it in a very high risk patient where there is So here it is a ultra low contrast. We had to give only 20 ml. GFR was 20, and we are doing everything. So here, we did it with the help of OCT and IVUS both. OCT was normal saline OCT, and Impella was put in this patient. And then we did a rotablation, 1.25 bar, 1.75 here, and then followed by IVUS. IVUS is not crossing. Very common story. And in the very heavily calcified lesions. So then we did, Shockwave using, this 3 millimeter into 12 balloon. And subsequently, we were able to did the IVUS, found out that whether the cracks were good or not, whether we are ready to put the stent or not. If not, sometimes even we go for high pressure inflations before putting a stent. So we did all that, did a OCT examination with normal saline. So this is a normal saline OCT because this is a patient where we wanted to do a ultra low contrast PCI. So this is a OCT, and here you can see that the result is very good, and we were able to achieve a good final result. Then last case is a stentless angioplasty in osteal lesions pure. We have done many cases now, especially for the circumflex ostium, where you do not want to put a stent, calcified lesion. What do? So we did a balloon dilatation, and then followed by Shockwave, and still there was some problem. So we did a cutting balloon here to cut some fibers over there, and then followed by again IVL using a 3 millimeter same balloon, and then followed by drug-eluting balloon with a very good outcome here. So with this, I think I will move out on this and tell you my final tips and tricks. So squeeze the pillow to break the plate. 1:1 balloon sizing is very important, which we do, and keep seeing under fluoroscopy or on OCT or IVUS to whether the lesion is giving way or not. Target the densest part, position the emitters well. Pulse delivery should be done, do conservation of pulses, but definitely do not throw the balloon. If you have more pulses, do give everything there. There is no point in keeping it. And then de-airing is must, because air absorbs the shock and may not give it properly. And of course, IVL cracks with no medial injury is the key to success. And single therapy for all calcium morphologies is the thing which we have learned and noticed now. Nodular, diffuse, eccentric, and concentric, everything can be done. So with this, I'll stop here. Thank you very much.
Thank you. We have not much for the discussion, but I hope that starting from with our panelist, Dr. Almogairi, can just have some comments on what has been presented so far.
Yeah, thank you. The presentation covers the phases of the approach, and the conclusion from this one, what I understood, and everyone take the message from this one, is all technologies are complementary to each other. Rotablations, the IVL plus the high pressure balloons. So to complete our aim by optimizing the result and reducing the MACE in the future.
Any burning question from the floor?
So last thing I want to say, when I do not use IVL, I do not use IVL when cost is a little issue, or I cannot do it because of any other reason. Otherwise, IVL is my first choice now in place because it is same wire, less time spent, quick, fast, and predictable. So, and less complications.
So only uncrossable, you start with a rota, uncrossable lesion. Otherwise, it's like IVL for every calcium modification.
Yeah, so as you can see, in our experience, we found that it is effective for almost every category of calcium, every category of clinical situation. So that is why, and one wire. So you don't have to change wires, you don't extra things, much faster. And imaging, of course. So imaging is, yes, very important. Imaging is very, very important to know pre and post. which size, and get the best outcome on the table at that time.
So the NC is used before and after both.
Yeah, so we do NC before also sometimes, like using a 2 or 2.5 NC to get good expansion, cross the lesion well, and otherwise post dilatation, post stenting, like about 80% times we do NC, 20% times sometimes we are not needing that. Once we do imaging, if everything is okay, good lumen, we stop.
So only thing is about the IVL is the availability of the balloon. If the balloon is a balloon non-crossable lesion, then the rota serves the purpose most of the times. And when we have used a rota, then after using the rota, if we have to use some ancillary balloon, then the cutting balloon is the first choice and does the job most of the times. It saves the costs also. And after the rota, using an IVL, especially in our country, it's really escalates the cost so much. So in the balloon crossable lesions, and I think the IVL is the best choice, but in the balloon uncrossable lesions, rota followed by a cutting balloon, if required, is the best option.
I tend to agree, and I believe that's the only caveat that Shortcut told us. I mean, if there is a rotational atherectomy, first try with a balloon, and most of the time you don't need it. Also, rotatripsy is also a very effective, very safe approach for some extremely complex, extremely calcified lesions. With that, I'm afraid we have to close. It was a little bit longer than expected, but as you have seen, there is a lot of data new presented, and I hope that we gave you an idea for those of you who couldn't attend TCT or PCR reporting the most recent trials, and this has been complemented by the beautiful cases of Dr. Chandra, 700 cases of personal experience. And my views, you did more than me, but certainly he had very practical tips that I hope will help you in your practice. Thank you.